we're delighted to have Dr. Armin Schwarzbach with us this evening. Hello, Armin. We're doing
Hello.
this in a slightly more informal way than
Hi,
we
Armin.
usually do, in that everybody has the same sort of window space, really. And after Armin has given a shortish presentation, everybody will be able to open up their microphone and speak if they wish. And of course, everyone can open up their screen and we can see their face. So that's lovely. And so Armin will speak for about half an hour. And I'll just introduce him briefly for anyone who doesn't know him. And I don't think there's anybody who doesn't, but anyway. He's a world expert in the field of laboratory medicine and infectious disease. He's committed to working tirelessly on refining the various diagnostic tests for Borrelia burgdorferi, the causative agent of Lyme disease, and all the multiple infections that occur with it, as well as viruses and many other conditions too, like parasites and molds. His unparalleled experience and expertise in testing in this field culminated in the creation in 2015 of his own laboratory, Armin Labs, in Augsburg, Germany. He has a hand-picked laboratory team and has processed many, many thousands of samples from patients with tick-borne disease and others. And so we'll be listening to him now for a little while. And then afterwards, of course, do put questions into the chat or the Q&A as we go along. But afterwards, you're very, very welcome to open up and speak to us. So Armin, thank you very, very much. Over to you.
Thank you very much for the kind introduction, Gillian, as always. Welcome to all attendees this wonderful evening. We want to talk about the facts about Lyme disease testing. It's not about other co-infections and viruses. We have also presentations about that. So very important is that you need to know our agenda today. We talk about the CDC approach, the traditional approach your NHS doing, the German NHS is doing, CDC is doing. We will talk about the T-cell tests, the cellular immune responses, one of my specialties, the quality of the tick-plex test, especially also for the persistiforms, the intracellular test, and that we also will find a way that it's not just the Lyme disease patient in front of you. We find in every patient multiple infections, very important to mention that point, or we don't find Lyme disease and it's a so-called co-infection. We will talk a little about the correlation with scientific articles, for sure, because we need evidence nowadays, and accreditation, which is next week on 12th. You're invited to our accreditation talk about different accreditation aspects with Professor Gilbert from Finland. So Borrelia Lyme disease is based on an NHS test. It's your authority, and they say we adapt the CDC system, the Center of Control system from America, which is not the correct way to do that, because in England you have different subspecies, different antigens. We have in Germany also different subspecies. So normally every country should have our own test system, but we all adapted the US CDC system, and we are still using it. It was established 1994 in Dearborn, Michigan, and there's not a distinction nowadays in your system. It's not the differentiation between IgG and IgM in the first T test. In the second tier test, this is we name it a confirmation test. It's only carried out when the first test is positive, or we say borderline indeterminate. In the CDC system, we have a huge problem. Also your NHS, our German system, that we cannot tell anything about ongoing infections. It's therefore, to me, not appropriate testing. It's pretty clear if you have a Bull's-Eyre, a Lyme disease fresh infection on the left side. We learned about that just 30-40%, up to 50% present erythema migrans, typically the others not. So, but then it's pretty clear. Normally, you don't need a test. You could do an ELISpot, a T-cellular test, because it's very early representing T-cellular immune reactions. But if you don't find antibodies, this is not excluding Lyme disease in a very fresh phase. And also in the NHS system, then you should offer an ELISA test. You could do that. ELISA is the first tier test. We know that there's a massive insensitivity, massive weakness of this ELISA test. And then the NHS tells you, okay, if you're still not clear with the symptoms, they are ongoing. So the question is which symptoms? Maybe a Bell's palsy could be a second phase of this infection clinically. Then repeat this test. But we know there's a lot of patients, they don't present any antibodies. That makes it really problematic. And the Western blot, immunoblot, is just for confirmation. I think that makes sense to confirm it for sure by confirmation test if it's positive or borderline, but not if it's negative. So in negative cases, in the very early fresh infection, we should really do the ELISpot test to fill the gap. IgM antibodies, they generally, this is immunology, they document a recent exposure, but they dissipate very swiftly. The IgG antibodies only show a post-exposure or infection. This is, I think, a lot also of, I'm on the ILADS, ILADF board, and a lot of doctors, they misunderstand this aspect. They say, if I have IgG, I have Lyme disease. This is completely, I don't want to use the word bullshit, but in this case, by our traditional learning at universities, every immunologist is shaking their heads. IgG, what is IgG? It's a past infection. Hey guys, it's not active, it's not an ongoing infection. It's completely nonsense. If somebody is teaching that, this is against all of our knowledge. And I see Professor Gilbert was also a little smiling to that aspect. She's an immunologist in this field also. Leona, you're welcome. You could also say some sentences to that. But the IgG means a past infection. That's not a discussion with your CDC or with CDC in America, with your NHS, with our authorities. IgG means a past infection. And if you treat just on an IgG antibodies, to make it clear, this is not an argument where you could use antibiotics. The Lyme disease symptoms are not so highly specific. You say, I have now IgG, I treat the IgG. No, you never treat an antibody. You treat always the symptoms. And you know, Lyme disease is a clinical diagnosis and it's not a laboratory test diagnosis. Laboratory tests support you in your clinical suspicion, as it is with many other infections. Also, Bernd Dieter, you're welcome. Bernd, welcome from Germany. You support us. That's very friendly from you. He's one of our oldest experts, to mention that. Maybe you could say also some sentences, what I'm talking about now. IgG doesn't, no, not now, Bernd, later on after my presentation. IgG means a past infection. IgM, if you find IgM, okay, then we could discuss. It's, I say, oh, it's a very fresh infection. Maybe it's a recent infection. It could be a reactivation. It could be a reinfection. So because Borrelia doesn't give you any immunity, we know that. That makes problems in the vaccination part. But the IgM alone could be also a little unspecific. We know that from virus infections, as an example. So also our main competitor in America is also mentioning now that it could be cross-reactive with parvovirus B19, which is a special virus from Professor Gilbert. She's an expert for that too. So IgG, what does it mean? Past infection. IgG could happen, could vanish, could go away, or never happened. The IgM is the more important antibody in all of these infections. The CDC, again, they said in an overview that IgG is produced in a delay response. We learned that also from SARS-CoV-2 infections, that a lot of vaccinated people or patients, they don't produce after infection IgG antibodies. This could depend also on IgG subclass deficiency. So if you have a weakness of IgG production, and Borrelia burgdorferi, interestingly, is doing IgG subclass deficiencies, a lot of infections can do that. IgG1 could be suppressed, IgG3 subclass, these are the main subclasses in bacterial infections that are suppressed, and you cannot show any evidence in IgG. So why should you test for IgG if you cannot produce that? So maybe a tip for your side, it makes sense in very immune suppressed patients with corticosteroids. If you measure the total IgG IgG, total IgA, and total IgM. We have it also in some IgM. These are the secondary immune subclass deficiencies. So IgG is helpful in a prior infection, or as I mentioned, in vaccination. They are on the way for these, but it's still not available. The tier 1, the ELISA, if it's coming up positive, it has a sensitivity for detecting early acute Lyme disease. But you have learned, if you have a bullseye rash, you don't need a test. You treat the bullseye rash after tick bite. It's pretty clear. Okay, we have some atypical bullseye rashes. In such cases, it could make sense to do that ELISA 2-tier, but I would really recommend you the ELISpot test. Why? Because this T-cellular immune response is always in the phase before you develop any antibodies. So you need up to 7-10 days to develop IgM. But in this phase, the lymphocytes are infiltration is ongoing in these bullseye rashes or lymphocytoma. And in this case, you find this ELISpot I show you later on. It's so pretty clear. In the tier 2, the immunoblot, or some, they say it's Western blot, or we have also the Southern blot and the Eastern blot. Interestingly, it's a little history. In the Western countries, we use the Western blot so that you understand where this is coming from, this expression. The Eastern, there's not an Eastern blot, but we have also a Southern blot. So there are different names for the same technique. And if you have such an IgG, IgM Western blot shows up, it is most likely to be recent in the IgM, but not in the IgG again. If you just have IgG antibodies without IgM, this means past infection apostrophe, nothing else. And you should not treat these conditions. Just if you do now a follow-up of these Western blots and you find more bands later on, you find a dynamic process, then we could discuss about reactivation, maybe chronicity of this infection. But with one antibody test, we say in laboratory medicine, one antibody test is no antibody test, but you always should do a follow-up because it's a dynamic process, always. It's a protein with a half-life time. It's always changing from day to day, from week to week. I don't want to say it doesn't make sense to do antibodies, but to me, these are screening tests, nothing else, but they cannot tell you anything about ongoing activity. So this was pretty clear shown by Basanpuri, your famous professor, let me say so, with Michael Cook. Basanpuri is really great analysis doing. We publish now a paper about anaplasma and ELISpot tests and ANA titers. I will present at ILETS in Lisboa about that. So interesting data we got about the ELISpot, but not about the antibodies. You see here again the antibodies, ELISA. We have just sensitivity of all manufacturers, although they are CE certified, IVD registered, around 62 to 60, 62.3 to 62.4%. And again, also the Western blot, if you use the Western blot, which is a higher sensitive test, okay, Western blot is more sensitive than the ELISA. So why should you not do a Western blot and forget about this ELISA? ELISA is a very, very complicated technique to bring all of these different antigens of all different subspecies onto one particle in the test system. Professor Gilbert can tell you more about that. So we have a lack of, let me say, around 70%. We could fail by 60 to 70% by ELISA. And again, if we use a Western blot, we still will fail, 40%, 37.5% on average there. So FDA cleared commercial serological testing for Lyme disease is inadequate for the diagnosis of the disease, with the problematic that IgG cannot tell you an ongoing or an active infection. So the seronegativity is a very huge issue for me now 20 years when I found the first cases. Also, if you do spinal fluid, we have the same situation. You cannot exclude in the spinal fluid neuroborreliose. It's impossible, so you cannot do that. It's so complicated with the IgG, with this indices to compare and to measure them. So therefore, in 1988, the T-cell tests were developed. Nowadays, we name them ELISpot, which is a modernized technique. In this time, they used a special technique or a very ancient technique. It was a blast technique. If you go into literature, it's very old, but 1988. And if you go into that paper, these are the leading authors who did Detweiler the CDC guidelines for the antibodies. But they didn't mention that there's a fantastic T-cell test, which is so helpful also in all kind of chronic, and it's in the paper of chronic Lyme disease. They didn't mention that, you know. It was completely suppressed. I don't understand that. 1988, I was not so active that time in medicine, but the older guys like Dr. Huismans, he can tell you a little more about the history. It was completely, knowledge was suppressed in the guidelines. So the question is why. This is more a political thing. Why should we not use a test which was published from the leading authors in 1988? Nowadays, the ELISpot. Why should we use it is an overview. You could get this 17 pages. Stephen Phillips showed at Leona Gilbert's conference in Finland, I think that time. He showed clearly that we have so many false negative or Lyme disease patients or other spirochetal infections where the antibodies doesn't help you in any way. So remember back, ELISA doesn't help you in any way. So I avoid the ELISA, to be honest. Just the Tickplex, we come later to that for the persister forms, which is closing the gap. So activity, we know, but it's not in the guidelines again. And we need to bring it into the guidelines. We do it now in the germ borreliosis guidelines. So we need to bring it into the guidelines of CDC, NHS, but they ignore these papers, which are evidence-based papers. So the importance of the T-cell tests, I talked a little about that. The question is, what tests should we use now for chronic conditions? We are talking about chronic conditions. As you have seen how patients can fall between the cracks with standard NHS tests and IgG tests only showing past infections. And this is a little a short chapter about the T-cell test to mention. The ELISpot test all is 20 to 200-fold more sensitive than any antibody test. So they use it as gold standards in transplantation medicine everywhere around the world. Why? Because if you have a kidney transplanted patient, the patient is strongly immune suppressed and you don't find any antibodies. That's pretty clear. But you use just an ELISpot in this university in institutes for especially Epstein-Barr EBV virus. It's in the guidelines. The ELISpot technique, you use it and you find 1 or 2 or 3 cells, and that means that you have a problem with the donated kidney. You have a problem with it, you know. This is a very, very sensitive test, very, very sensitive and fantastic, in my opinion. The stimulation index is how it's measured. And the next paper about, everybody says, yeah, it's unspecific, it's not, this is also not correct, it's incorrect. We have very high accuracy, we have a high sensitivity, it's reproducible and very robust. And some name it already in 2014 a gold standard. You know, 1988 it started with the first papers about the first generation, and now we're coming more and more to gold standard and bring it also into many guidelines in the world. And in 2024, Professor Gilbert motivated us to write a chapter. Also, one of the authors is here in the audience. It's Markus Berger, and Dr. Putiano and myself. We published a paper, and we said clearly that it's not a test we are doing, or it's not a scientific test. Many laboratories are convinced. Also in Germany, we are not the only one offering the test. Also for Dubai, we are not the only one offering the test. But many clinical laboratories are convinced that the cellular assays are superior to the Western blot assays in terms of sensitivity for detecting the underlying Borrelia infection. That doesn't mean that I want to make all antibody tests bad, or it should be a dark light on this. No, that's not correct. Antibody test is always Th2 testing. ELISpot is Th1, and both complement each other. Okay, so some patients, they are overpacing or overproducing Th2, so they produce antibodies. After a while, this is also my experience, you have a shift from Th1 away from ELISpot to the antibodies. And then you could find, maybe if you treat a patient successfully with Lyme disease, you find antibodies. Wow, there are antibodies. But the ELISpot is also coming back positive again. So that means, in a conclusion, the ELISpot, to show T-cellular immune reactions, is not a bad thing. But in the end, the patients are sick. But if you would not have any T-cellular immune reactions, you would not survive in the world. You know, everybody has T-cellular and B-cellular immune reactions. This is our natural immune defense also. But the problem will come with the interferon gamma. And the ELISpot is based on Th1 cell interferon gamma release. It's a cytokine release test. It's not a proliferation test. Some laboratories are offering proliferation tests. What you can see here in this case, it's the full antigen is done from sensu stricto, the joint arthritis. The OSP mix is done from the antigen of Gariniae, a combination sensu stricto and Afzeliae. So in this constellation, I would clearly say to you, your patient has musculoskeletal symptoms and has also some neurological symptoms and has fatigue. Why? Because the OSP mix, Gariniae, is included. And this is very tricky. We worked a lot with Kenny Merlet a long time ago, and he is a chronic fatigue specialist in Belgium. And in his samples, we always found the OSP mix positive, but not the full antigen. All of his patients had chronic fatigue, but not musculoskeletal symptoms. He was a chronic fatigue expert, you know. So you would say in England, ME, myalgic encephalomyelitis patient. The LFR1, the shared epitope, this is where we published now a lot of papers with Basan Puri in fibromyalgia. The LFR1 is a lymphocyte function antigen 1 in the test system. We name it a shared epitope. And if you find this positive, please always check for collagenosis, rheumatoid arthritis, vasculitis, and fibromyalgia. There's not a test for fibromyalgia, but we are the first group in the world, we found association in fibromyalgia, 30% ANA titer positivity in correlation with Borrelia burgdorferi infections LFR1. So it's pretty clear that Borrelia burgdorferi, the pathogen, induces, by the mimicry effect, we name it, it's a similarity of the antigen on the surface. In the immune reaction, we have our own destruction process of the anti-nuclear antibodies. And if you treat such patients, therefore you need the ELISpot also in fibromyalgia and rheumatoid arthritis patients. If you treat that patients, you have a good chance to destroy Borrelia or bring it intracellular, bring it into a silent mode, a sleeping mode. And if you can remove, maybe if you are lucky, the ANA titer and CCP antibodies and ANCA antibodies in your patients. And also we know that Hashimoto's has to do with that. Borrelia burgdorferi is a triggering factor for many autoimmune disorders. The methodology of the ELISpot test, it's a standardized test. It's CE certified test, IVD registered test. It's a CAP accredited test from American authorities, also for Lyme disease, for Borrelia burgdorferi test. It's a very, very standardized test. We incubate that in this blood. They sent from many countries in the world to us, from Alaska and from South Africa and from Australia. We have up to 4 days time to start with the test. You take the blood on a Monday and we need to start on a Thursday, but we want the blood as fresh as possible. Why? Because if there is any logistic delay, we put pressure on the logistics for Markus Berger. We say, okay, we need the blood within 2 days maximum, so 3 days, to keep the pressure on it. And this is all accredited with authorities, with American authorities, and they check this if we follow up the rules. It's a second antibody test, a second antibody complex added to that. And what you can see on the left side on the button, these plaque spots, spot technique. Every spot in this wall, a little, was one lymphocyte. Well, lymphocyte is dead now, is killed in the test system. It was one living lymphocyte which did a secretion of interferon gamma in the combination with the Borrelia burgdorferi antigen in the well we put into the well in the test system. And you could say this is a positive result with many spots. You can count them. We have a standardized counter for that. It's very good counters nowadays. It's not an automized test, so it's still a lot of handwork. But these robotic systems, they have also massive failures if you do ELISA tests or if you do some are doing Western blots, immunoblots with robotic systems. I'm not the fan of robotic systems, to be honest. The next generation came, and the next generation was developed by AID company. I think this is the leading company for ELISpot production in the world. Also to mention your company in England, also this quantiferon test was coming to you. So we had the ELISA also from Stejskal in Sweden. So we have different test systems, and the really good advantage is we could compare these results we are doing with blinded samples. So we don't know what's in this patient sample. We do control checks with other laboratories. So because it's a CE certified and IVD registered test. In this next generation, that was a good idea. It came from Coxiella burnetii infections. The test producers thought about what is the main cytokine of a past infection. And they found that interleukin-2 is one of the, it's not the only cytokine you could detect in past infections. We name it cytokine profiles for pathogens, okay? So interleukin-2 would be the best one. And then they put both in a new modern test system technique with a fluorescence reader. It's a different reader. We have 2 readers, 3 readers in laboratory. We need substitutes. Also, it's interferon gamma positive or negative tests, interleukin-2 positive negative tests in the combination. What does it mean? If interferon gamma, the green aspect, if interferon gamma is positive, interleukin-2 negative, you have an active immune answer to Borrelia burgdorferi. This is clearly an indication for treatment follow-up after treatment. So it's also for staging. It's a good follow-up marker, this iSpot test. But please, you don't treat a laboratory test result. You should always check, is it a suspicion for Lyme disease? Is it ongoing Lyme disease? Clinically, not by IgG or IgM. That doesn't make sense. You should see the clinical aspects in the foreground. The laboratory is still supporting you if you're right or not right. And then you could take a much better decision if you need longer antibiotics or if you start antibiotics. So if interleukin-2 is negative in this interferon gamma and the patient has Lyme symptoms, then treat. If interleukin, the gray on the right side, if interferon gamma is negative and interleukin-2, no Borrelia infection, no treatment. It's very sensitive, 20 to 200-fold more sensitive than any antibody test in the world, okay? If you have now this yellow area, it means the balance between interleukin-2 and interferon gamma both are positive. This could mean a persistent state of Borrelia infection, and you need for sure diagnostic verification and monitoring if clinical symptoms remain. So keep an eye on this patient. You don't treat the laboratory test away, you don't treat IgG away, no IgM away. These are natural immune reactions. You expect zero conversion. So you expect here the conversion from interferon gamma to interleukin-2. And the red is on the left is the best one. If you have patients with interferon gamma and no interleukin-2 positivity, this still could mean a latent or hopefully a cured patient of a Borrelia infection. We have many problems with latencies, as we have it with viruses also nowadays. We know that they stay in us and could be reactivated by immune suppression or inflammation. And therefore, we have this later on the wonderful tickplex test from Professor Gilbert. Thank you, Leona, again for developing this. The Borrelia iSpot. This is an example. What would you say now? We have the full antigen 4 stimulation index. We have OSP mix is negative, LFR1 is negative, full antigen in the interleukin 2 is 2. It's a weak, a borderline result. So this is a patient, I would say without knowing this patient, it's a positive cellular activity against Borrelia burgdorferi against the full antigen. That means this is a patient with musculoskeletal symptoms. I would say that to you if you discuss it with me. And you say, yes, how do you know? Yes, because full antigen is positive in the ELISpot. LFR1 is negative, so I would say there's not a high probability. There's a good thing for autoimmune disorders. Okay, so I would not recommend to do the ANA titer from the aspect of Lyme disease. Maybe ANA and CCP and rheumatoid factor, they all were done. Okay, but still, there is ongoing infection. This is on the way. You would say in serology antibodies, it's a seroconversion away from IgM to IgG. This is the same aspect here, but still the patient has interferon gamma, and these patients all have pain because it's cytokine, and cytokines, it's inflammation marker, they make pain, also neuropathic pain. We discuss it every day with therapists, and we are absolutely on the right track by that. So this is how it looks like, a positive, and not that you say it's unspecific or it's not verified, it's not reliable, all nonsense. In every test, we have you don't pay for it. It's free of any costs. We do a positive control and a negative control, okay? In the negative control, there should be nothing in it. In the positive control, it should work. So we can say exactly if the test is valid or not. This is the precondition of accredited laboratories, positive controls, negative control. So if the positive control is a little weak, we mentioned that, we say you have a weakness in interferon gamma release. So we see that with corticosteroids, or if you have patients with virus infections, they suppress the cellular immune responses in the interferon gamma. So there are different aspects, but we mentioned that. And you are the clinician, you need to think about that. What is in the background? Why is interferon gamma so overpacing so strongly in the positive control? This we see very often in herbal treatments and immune stimulating treatments. I can tell you, if there is an overproduction in the general, it's a pockweed control, we name it, of all lymphocytes, then I mention that and I say, you stimulate the immune system. It's overpacing. No? It's too much, but it's good. Maybe your herbal therapy is working, which is good for you. Here, a lot of references. If you don't believe in that, it's pretty clear. We have more and more references we find about that. The more also we work with Mr. Google, the more we find from the past. That's now fantastic. Although when I was student in the 80s, we didn't have internet, and my PhD work is not published. So you will not find my PhD work. It's at universities, and maybe they destroyed it now. So our older work is not published, guys. So we have a massive disadvantage. Also, my fantastic work in this hormonal, where I worked on the development of radioimmunoassays. So it's still not there. So I'm a little, I could cry about that. This is to show you. Interestingly, when I found that paper, it was published in 2016. It shows clearly by CDC, the IDSA, it's CDC criteria. They said that the ELISpot, that the measurement of interferon gamma with Borrelia antigens, ELISpot test, could be useful in the laboratory diagnosis of early Lyme disease. Why? They compared the antibodies, also C6 ELISA at that time, and Western blots with ELISpots. And they found that ELISpot is much better reflecting successful treatments after bullseye rashes and not the antibodies. Nobody was following that up. This paper, but it's a highly ranked evidence-based paperwork. So, okay, you could say it's still on a pilot level, 29 patients, but somewhere it's published, and we need to start with something. Okay, now we come to Professor Gilbert's fantastic tick-plex test around the world, conquering the world with the persister forms. So I know that time, Leona, when we were at the Finnish sauna and we had great success in the high license project with the European Union, they gave us 8 million euros for developing a better test for Lyme disease. And we had this test that time. It was a lab on a chip test system. But what was the difference? Professor Gilbert, she's a genius. She found out that she could develop a test for persister forms, antibodies. Okay, and in this case, you see IgM. For it's down, you see the 1.565 ratio for positive Borrelia round bodies. They name it round bodies, or pleomorphic forms would be the correct nomenclature for it. This is persistent form antibodies. So this closed the gap, or is closing the gap to this. Remember back to the negative, seronegative chronic Lyme patients with no antibodies, no IgG, no IgM. We find that now in the Western blot. And this gives us a very, very useful information for persister forms, for round bodies in the IgM. So this could be a reactivation. Be careful from intracellular to extracellular. On top, you see the ELISA against the whole spirochete, which is a combination of all three main different subspecies, Scarinia, Afzelia, and Sensu stricto, which is reflecting, I would say, 90% of the Lyme patients. We have some others which are rare. These are the round bodies, and we said in our paper with Professor Maryline that time, she did her PhD on that in 2015. So, it's jubilee, 10 years ago. Wow, Armin Labs had 10 years now, and also Leona has 10 years now. Wow, 10 years ago it was published, and Professor Maryline, her PhD. And you see the biofilms on the right side, the green slime. We don't have a test for it. So my challenge for Professor Gilbert, develop a test for these biofilms. Maybe we could do a blood test for biofilms. There were some, it's difficult, I know. Nevertheless, we need to treat it. We know that they are producing. But that time, Leona, we exactly, when we discussed the round bodies, these persistent forms, we said pleomorphic or round bodies of Borrelia burgdorferi should be taken into consideration as being clinically relevant and influence the development of novel diagnostics and treatment protocols. And now we got it from you. Thank you so very, very much for this fantastic development, which closed the gap for many sufferers. I have myself persister forms, but I'm not sick, so I keep an eye on that. Thank you. If you need a positive control, I'm one of that. So thank you very, very much. So there are a lot of literature paper about round bodies, cystic forms, L forms, they named it Lyme that time, very old. Bernd, you showed me Lyme years ago. Yeah, what should you do? Not everything is Lyme disease, please, apostrophe. I say, okay, if we discuss Lyme disease symptoms, we discuss Coxsackie virus symptoms. If we discuss Lyme disease symptoms, we discuss Chlamydia pneumoniae symptoms, because many of them are overlapping. The symptoms themselves are not specific, but the combination of the symptoms, they make it more specific for a disease, pretty clear. This is how medical brains are working. Therefore, we developed that co-infection checklist. We have now a parasite checklist, a yeast and mold checklist. We have also multiple infection, a long COVID checklist, post-COVID, which are fantastic clinical checklists, evidence-based, a lot of work behind that. And what you can see here, the symptoms are not specific, the symptoms are overlapping, but still you get a ranking, you get an algorithm behind that, and some kind of artificial intelligence. And what you find in every Lyme patient, you find viruses, you find parasites, you find yeast and mold. And I think this is now also not just American way. We are also telling you that not everything is Lyme disease, but you need to start somewhere. And this is now automized, the checklist. We find a lot of Chlamydia pneumoniae, Mycoplasma together with Lyme disease. We find a lot of herpes viruses. I think it's more reactivation of the herpes viruses. Interestingly, also long COVID patients have a lot of HHV6, EBV, CMV, and as you know, Coxsackie virus, there's a new paper came out that 2/3 of juvenile diabetes patients they suffer from Coxsackie B1 virus infections. And Coxsackie B1 virus is destroying the pancreatic B cells, and then they get, during the time of hand, foot, mouth disease, and also herb angina, the blisters in the mouth, they got juvenile diabetes. So we have a chance now maybe also to treat very early with vitostatics these children, or this is discussed in the papers nowadays in the world. But we are now on the track to find out that also Epstein-Barr virus, EBV, 70% is doing in the multiple sclerosis part. So chlamydia pneumonia is, and these are all the biofilm makers, so we need the biofilm breakers. And there's a lot of correlation with a lot of these scientific articles and infections. Sorry, we go here. And what you can see here, now I'm running through. Yeah, these are the reference. It's some Chinese is in the presentation, sorry, Chinese model. There are a lot of correlations with a lot of clinical conditions you will see in the future, that the infections will break the ice, will give us options for treatments. Type 1 diabetes with SARS-CoV-2 long COVID patients, we have unique chances. Also, Lyme disease is reactivated or can be reactivated in long COVID patients. We have paper about that if you're interested. Multiple sclerosis.
Armin, could I just mention here that we've over the years collected scientific papers that link to all of these, haven't we?
Yeah. It's all evidence based.
Contact us.
Yeah.
And also, though we keep those a bit below the radar, also infections linked to cancer.
Yeah, this exactly. I want to say now, this is the chapter I opened with you, Gillian, also with the literature research. We have so much evidence that viruses and also maybe Lyme disease and co-infections are behind cancer. Remember, if you have a Burkitt lymphoma, this is an EBV reactivation infection, okay? If you have non-Hodgkin lymphoma, we find many with EBV reactivation, Epstein-Barr virus, and also cytomegalovirus. So we have huge associations with it, and we need to bring it also into the guidelines of the oncologists, which is a challenge, I know, but we will switch also the guidelines of the rheumatologists, for sure, neurologists. I'm so pretty sure about that. Everything needs a little time, but we have options, the others not. And this is good for us. We have options for the patients. We could help, and not to say every patient with such diagnosis, they have infections, but it belongs to the differentials. And if you exclude it, you exclude options, therapy options for your patients. Yeah, and now the last we will do next week with, you are heartily invited, with Professor Gilbert. She's much better in the ISO certification, accreditation. She's a test producer and a laboratory woman than me. But to mention as an example with our laboratory, my heart is the quality first line. So when I build up SynLab 20 years ago, my heart was always quality management. I don't want any tests which are on scientific level, nothing against phages, but they are still on scientific level. We need CE certified, IVDR registered, accredited tests, and then the authorities cannot attack us. It's difficult to attack, believe me. If you go into a lawsuit, you want to defend your patient. It's much better to have a CE certified, IVD registered test than not. If it's on a scientific level, it's scientific level. It's science. Science is not so accepted because you cannot accredit science. You can accredit certified IVD registered tests, but not scientific tests. This is a hard way if you would accredit them. Now in America, they are on the way to that. We will talk about next week. But I think it's very important also for NHS because everything is control checked now. What does it mean? We have in Armin Labs regular participation in inter-laboratory comparisons for all tests offered, also for the ELISpot. Otherwise, we would not have the full accreditation on all ELISpots by the American authorities, the CAP international authorities. We have independent annual assessment of all processes and procedures in the laboratory. We have the obligation, and this is now a little bottleneck for us. We cannot use, let me say, phages test because it's not IVD registered. It's we name these tests in-house, but we talk next week about that. We have an obligation to use only IVD registered test methods. And the European Union is now standardizing that. Also, I don't know in England what's your situation, but Leona knows better. But we are enabled by this independent verification of all results. And so they are reliable and not unreliable and not on a scientific level. This is a little, also I know the tickplex came from a scientific level, but then you showed by characterization of antigens in your huge paper, Professor Gilbert showed the tickplex, that is evidence, and then she got the CE certification, IVD registration in Finland. So, and a lot of laboratories can do her test now and compare the results. Army Labs does not perform any self-developed tests. We are not simply not allowed. So this is a bottleneck for us. Okay, we cannot sell Rantes because Rantes is not a not a certified test. Okay, it's an in-house test. It's a chemokine which is done in Nikos. Just another example. Every test is performed commercially. Okay, commercially means we need to check the market of test producers, and then we decide which test producer has the best quality, and then we buy the test from a test producer. We deal about the money. We say, okay, could you do it a little cheaper for the ELISpot and then we buy the test, and then we use the test. We are test users. Okay, we are the users. We are not the programmers. And very important, the validation internally. We do it also internally, externally, certification by many test manufacturers we are using in our laboratory. Also, what's very important if you are sending to a accredited lab, we have the European accreditation, including UCAS, the British accreditation, but this topic for next week. We need also stability controls that the samples you send us have really a long stability. We are not allowed to do a ELISpot after 2 weeks, so we can throw it away. So we have stability criteria which are strongly controlled from external authorities, as it is from America, from Germany. They come into a laboratory every year and they check us what we are doing. And we need documentation for that also. Short and long-term stability, it's very, very important how you send the sample. This will be a topic for next week. We have the freeze-thaw stability, also a chapter for cytokines, maybe, or for hormones. It could make a problem. We have the cell vitality, the test we are doing, living lymphocytes. So we handle them very carefully. We have an instruction how you should handle the blood. If you send by A&M, they are very well in this now established and instructed. You cannot centrifuge it, as an example. Some regulations need to be followed from your side when you take the blood for such tests. Yes, and also we have the real-time tracking of samples. So we show temperature differences also by thermometers we put into some of the test kits. We need to show that for our authorities and US authorities. So we need visibility into position and logistics. Let me say so. 70% of the quality is not in the laboratory. 70% is in the pre-analytics, what you are doing with the samples and the logistics is doing with the samples. So the laboratories don't fail so pretty much in statistics. So we need to work also on the quality, how we send the samples, in which tubes, how to handle the sample and how to process them. It's very, very important, and the temperature plays for sure also a role. Therefore, we have this protection around the tubes. And we have also alert notifications for deviations, and also we have actions, and we need, if something is happening with the samples, we get a frozen sample from Canada. It was so very cold now, so icy, that a blizzard there in Winnipeg. They were frozen. Yeah, we had problems. We could throw that away, and but we cared for fresh samples. They were not frozen, and then everything was fine. Okay. Yeah, the fullest accreditation possible worldwide. If you, in this chapter, we will talk about next week more, the German, which is a European for all European countries. They have a group there, the CE certification, the IVD registration of the test. This is the part for tickplex as an example, or the toxiplex or other tests. The UCAS equivalent, the ISO, we are fulfilling the high and the modern. We have now the modern ISO standard in our laboratories, which is really very, very complicated, but we fulfilled it. We got the re-accreditation. And for US, the CLIA, the CLIA, if you say, oh, I have a CLIA lab, this is a lab maybe on a scientific level. This is not what we are doing. This is not the high quality we are doing. We have the College of American Pathologists, the CAP, and this is also worldwide and nationally the highest standard for that. Yeah, and thank you very much for your attention.